So now, it is my pleasure to introduce our opening speaker today, Jennifer Kent. Governor Brown appointed Ms. Kent as Director of the California Department of Healthcare Services on January 26, 2015. She oversees a staff of 3,700 individuals at the department, which is responsible for the operation of Medi-Cal, the state's Medicaid program. The department manages the spending of more than $93 billion annually in public funds that supports the health of more than 13.3 million Californians. Previously, Ms. Kent had served as Executive Director of the Local Health Plans of California since 2013. Prior to that, she was Principal with Health Management Associations, Inc. from 2011 through 2013, where she advised clients on issues of healthcare reform. Her previous California government service included leadership roles in legislative, intergovernmental, financial, and health policy areas with the Office of the Governor, the Health and Human Services Agency, and DHCS. Please join me in welcoming Jennifer.
Okay, so good morning. For those of you that don't know me, and I always laugh when people read my bio because it sounds like I can't keep a job, which is in some cases really true. This department has now called me back 3 different times. So I started there in 2004. I left in 2006, 7, when the department was splitting. It was actually Department of Health Services, and we split between DHCS and Department of Public Health. And at the time, I was given a choice as to which side I wanted to go. And it was like asking, you know, I'm not a parent, but I know parents are out there. If you had to choose your favorite child, you know, the first child is always the favorite as far as I'm concerned, because that's also my birth order. But I left and went to Health and Human Services Agency, where I worked under Secretary Belche at the time and Governor Schwarzenegger doing health reform. And so that was an interesting year. And then after health reform in California failed, I went in and worked for Governor Schwarzenegger for the remaining 2.5 years, where I had all of the HHS assignment. I then inherited all of the health-related boards from Department of Consumer Affairs. I had Department of Managed Healthcare, which was under a different agency at the time, revenue and tax, alcohol and gambling regulation, and then Veterans Affairs. And so you're like, that's kind of an odd portfolio. And the answer really is I was the only, sorry guys, but I was the only female in the legislative unit. And so I basically was the workhorse. And so they just kept piling assignments onto me because the rest of the boys weren't keeping up. I think what the time in the Schwarzenegger administration taught me is that health reform discussions apparently come and cycle through. So what we're talking about today at a federal level feels very familiar, in that I thought we had already had this conversation once before, or twice before in California's instance, and so we're back at it again. Before I kind of give my opinion on federal stuff, I want to kind of lay out for you just a little bit about the department that I both work for today and that works for the people of California. I have about 3,700 employees, give or take. We're probably on the higher side of 4,000, but there's some that we hide under what we call a blanket in the state. So if you're under the blanket in the department, it's a code word for civil service. And the budget is over $100 billion this year. I always said I wanted to be the director that saw over $100 billion, but I didn't quite want to do it the way that it happened, in that we overspent our current year allocation. And so when we overspend our allocation, a $1.2 or $3 billion general fund over expenditure works out to be about $10 billion in total funds when you get the matching percentages out. Just for facts, we send capitated payments out to our health plans in the amount of about $4 billion a month. We contract with 22 plans. We have about 11 million individuals enrolled in managed care. We have about 2.5 to 3 million individuals that are in fee-for-service. The bulk of those people are what I like to say are on the highway to managed care, meaning that they have been found eligible for Medi-Cal. They're in their choice period, which is about 60 days, to choose a health plan. If they don't choose a health plan, then we put them into a plan through a default algorithm. Our fee-for-service population is composed, once you take those eligible people out for full scope benefits, dual eligibles, very small populations that are not mandatorily enrolled into managed care, such as foster care, and then individuals without satisfactory documentation status. And those are individuals that are only on for a limited period of time, only eligible for emergency coverage. And so our weekly check rate for fee-for-service is about $400 million a week. So if something gets caught up in our system from a claims perspective, you can understand why we get a little excited, because a lot of people rely on us not only to provide care in the state, but also the providers that rely on us to get those checks out the door. We have a lot of waiver programs that you may or may not be familiar with. Waivers, as I like to explain them to people that are not that familiar with Medicaid, they're essentially special programs that we go to the federal government and say, we would like for you to bend the rules a little bit and allow us to do something different with this small number of people, which is closed off depending on the condition or depending on the type of person that we're talking about. And it allows us to do a different scope of benefits for those individuals as a means of, rather than providing it for the entire population, which in some cases would be cost prohibitive. Obviously, one of the ones that you would maybe be familiar with is our pediatric palliative care waiver. That one was enacted by the legislature back in 2006. At the time, I was at the department. I was working there when this bill was going through, and maybe this was my exposure to palliative care, is the day that I had to testify on that bill for the department was the day that we had made a decision as a family to put my father into hospice. It was not a great conversation, right? My father had end-stage colon cancer. He died at 59. He was diagnosed at 57. It was a really interesting experience for me from the standpoint that obviously I know a lot about healthcare, but I kept looking at his oncologist, who also happened to be the county hospice director, and I kept wondering when we were going to have a conversation about palliative care or when we were going to have a conversation about hospice. My father's numbers had been dramatically changing. He'd been failing off of various chemo treatments. He was no longer a surgical candidate. And I had visited my father in the hospital, and he was sitting there, and he had just booked a $15,000 vacation for my mother and him to go somewhere in August, and this was April. And I remember looking at him thinking, you're never going to survive long enough to go on this trip. But in my father's mind, he was. And so I started to see the mismatch of how this was working out. And so I sat down with my father and had the conversation about, how do you want to spend your last days? Where do you want to spend your last days? And how can we be helpful in making you both comfortable and kind of having quality of your time as opposed to quantity? And after that conversation, my dad decided to go into hospice. His doctor came to me and said, you know, I'm really glad you had that conversation with your dad. And I remember looking at him and thinking, you're a real jerk, because I shouldn't have to be the one to have that conversation with my father. His hospice experience was not great. And I can remember towards the very, very end, the last couple days, my husband saying to me, the only person that's going to be more surprised when your dad dies than your dad is going to be your mother. And that was true. Last maybe 2 or 3 days of my father's life, my mom was like, God, I just wish, that he could really keep some food down so that he could get his strength back. And I remember thinking, okay, this is not happening. And so I think, I share that because I come to the palliative care conversation with both very personal experience. I'm very aware of the failure of the healthcare delivery system to, in some cases, admit its own failure, and that they hit a point in a disease state in which physicians don't know what to do with a patient. They don't necessarily want to have that conversation. They don't want to admit that there's nothing more that can be done. And so I feel really strongly about how do we get more comfortable talking about quality versus quantity, and where do people want to spend their days? How do they want to spend their days? And are there ways that we can help make people more comfortable and both at home as well as helping families have conversations about things that usually are avoided at great cost and great expense. Now, shifting off to the fun stuff. You have heard that there are changes afoot on a federal level. And I have really big feet, so when I say they're afoot, they're really afoot. Someone told me the other day, and it was probably a little too soon, they said, well, Jennifer, you got to be part of the conversation about reform before it was ever, even a possibility. You got to help put it together, you got to help implement it, and now you get to help take it apart. And I was like, too soon, not funny. But I think we as a department and we as an administration are obviously looking at what the proposal was that was released by the Republicans last week. All fall, we kept telling people we're not speculating on what's going to happen because it doesn't help us do our jobs, and it freaks people out. And so we didn't run models, we didn't run scenarios. I could have dreamed up 1,000 different items that the Republicans could have proposed to reform or replace or repeal or whatever they want to call it, redo the Affordable Care Act. But it just wouldn't have done us any good, and it would have wasted my staff's time. So we didn't do those things. When we got the proposal last Tuesday, that's when stuff started to get a little bit more serious, and so we are in the process of figuring out kind of these per capita allocations that they've proposed. We're looking at what we think happens to the Medi-Cal expansion population as they have proposed that it be phased down or phased out. I think Secretary Dooley said it best yesterday, which is we're pretty sure, in fact, we're absolutely certain that we will be worse off under this proposal than we are today. We have about 3.5 million individuals that have come into Medi-Cal since 2014 as we say, the optional expansion crowd. That's being funded today at 95% federal funds. We just are having to pay a portion of that 5% in this year's budget. That works out to be almost $1 billion, and in a full year's cost, it works out to be $1.8 billion on the state. The federal government picks up 95%. When that phases down to 10%, it's going to be about $2 billion a year. Or actually 4, because that's, 1.8, and then, 2. So 4. And these billions just kind of add up. They're simple numbers, right? 1, 2, 10, 12. I think what people should appreciate, though, is, as states as big as ours, where we have literally done everything under the Affordable Care Act that we could possibly do. We've done the duals demonstration, we did the ACA 1202 payments, we did the Health Home State Plan Amendment, we did the Medicaid expansion. I mean, if there was something in there, we certainly went for it. And I think the idea that you have millions more enjoying coverage today that are either able to work or able to not put their family into financial devastation due to an illness is a little bit of a frightening thing to think that that's all going to be phased out. But I think we are working to figure out what the fiscal ramifications are, but suffice to say that that is a very real threat to us. There's also some significant changes as it pertains to children's Medicaid eligibility, in which there would be a gap for those kids that we would have to figure out how to cover them between 100% federal of poverty level and 133% of the federal poverty level. There's a loss of federal funds for states that took advantage of the community choices option, which is in-home supportive services. So obviously you would be fully cognizant of how important we feel keeping people at home is a much better option than institutional care. We have about 480,000 beneficiaries today that are in the IHSS program, served by about 500,000 providers. It's about a $7 billion a year program, and that funding formula change has a loss to us upwards of $500 million. So we're putting this together. It's fairly sobering. I think the news that we're seeing coming out of DC is nothing different than what you're seeing, which is people are starting to wonder why we are doing this. I certainly wonder that myself. I think that you will see us hopefully come out with something a little bit more concrete in the next week or so. But like I said, it's a fairly complicated fiscal from our perspective. We have a lot of moving parts. We have a lot of delivery systems. And so when you start to talk to us about how do you aggregate your expenditures, how do you put them into categories of eligibles, it's not as easy as some states have it. So the other thing, and I'd rather take questions and have more of a conversation rather than just stand up here and rattle on, that I really want to kind of talk a little bit about is not only are there changes happening at the federal level, But we have our own state budget that drives a lot of concern and a lot of cautionary tales on the state side. You know, I like to say, and again, back to the days when I was in the previous administration and I had that revenue and taxation assignment, our tax base in California, capital gains and personal income tax are kind of the economic canaries in the coal mine. And so when you see those tax revenues start to drop off, it usually means that we're in for a fairly significant problem in California because we are hyper volatile on those two tax sources. We have seen a slowing in those revenues, and so what you have been hearing and that you saw in the governor's proposal in January is a very kind of cautionary approach, which is we're not completely pulling the emergency ripcord and saying we're in a big problem, but definitely seeing the signs of those revenues starting to either not show up at projection levels or to slow down means that we are certainly not either investing in new programs, or in this case in January, there was several initiatives that we said we're going to put those on the back burner. We're going to wait to see what happens in April when tax revenues do come in, and then we'll make some changes in the May revision if necessary. So one of those items that we had to put on the back burner was the implementation of Senate Bill 1004, which was enacted by the governor a couple of years ago, carried by Senator Hernandez, who has obviously been a real champion in this area of palliative care provision. I would like to say that, yes, it's been slowed down. That was mostly in recognition of the fact that we required some resources within the department to do some of that work and some of that plan oversight. And so there were several items that were basically held back. This is one of them. The whole child model under the CCS program was another. A lot of this is more cognizant of the fact that there were some additional general fund costs that were going to be required for us to continue doing that work. And so it was a decision to kind of slow those down rather than either eliminate them altogether or completely nix them. And so the good news is that it's a slight change in the date for implementation and not a wholesale just undoing, which has certainly been both an option and was rejected at the time. All that being said is that if April revenues come in worse than we would like them to, then that's a whole different series of decisions that we would have to make. And you know, I like to remind people in Medicaid, we don't have a whole lot of budgetary triggers. So it's people, it's benefits, it's rates. Those are the only things that I can really do to affect change in my budget. And obviously, when I have $100 billion, I have to cut pretty deep in order to make up for very big differences. And so a lot of times people say, well, I'm very small, so please don't cut me. And I'm like, yeah, but when I take you and extrapolate you to the entire state, and I consider all the provider rates and all those other things, you actually blow up to be like a $1 billion. So I would just, I'm not saying that we're in danger yet, but I would just like to note for the record that given all the federal uncertainty and given what the state revenues are like, you will see a very, very cautious administration, just because if you have not lived through the budget changes in 2008, did anybody raise your hand if you were kind of doing legislative policy budget stuff in 2008, 2009? Okay, so there's a couple of you. I was in the governor's office when we had a $60 billion budget deficit. So $60 billion in general fund is stunning. And even if I had basically eliminated the program, the Medicaid program, we still wouldn't have had enough money to get ourselves out of that hole. I had people coming in and meeting with me. They would cry in my office and say, if the governor cuts this program, I'm going to die. I'm going to be forced out of my home. I'm going to lose this benefit. I'm not, whatever. It was all bad. And I remember someone saying to me, this just isn't the right policy choice. It's not a good policy choice. And I was like, oh, we blew past good policy choices a long time ago. Now we're just making choices. And that's a very bad place to be. I don't want to be in that place again. I'm probably the last person that wants to revisit that area of discussion. But I just, I want to thank you for both your patience and your working with us on the provisions of 1004. I think that we're going to continue to do as much as we can without the requisition of new resources. I think we're looking at our health plans and seeing some areas in which they can continue to do work that we can facilitate indirectly. And then obviously, once we get the green light from a resource perspective, you will see a little bit more effort in that area. I will leave you with the fact I noticed that the hospitals are out here having a meeting today too, is that we have a small number of hospitals in our PRIME program, which is our Medicaid waiver program, that have specifically chosen palliative care as one of their projects that they're working on in order to draw down federal resources. And so I'm happy to both share more information about that. It's on our website, as well as to highlight the hospitals that are working on this. But they've got 6 metrics that they themselves have chosen in terms of, how do we drive more people into palliative care services? What are we doing to alleviate pain and other symptoms associated with serious illness? And then how do we both incorporate and use palliative care providers for individuals that have been diagnosed? And so there are certain things, even though you may not see it, there are a lot of activities that we continue to do in spite of the delay in SB 1004. So with that, I'm happy to take questions. I was told that you're a shy group, and so I would like someone to prove me wrong, or else I'll start to call out people in the room that I actually know. And I think there's microphones in the back that they want you, or in the sides there, if you can use those so people can hear you. They might try. We're going to drive you to the mic, but we're not going to turn it on. Just yell, and I'll repeat your question if people can't hear it.
Orange County, and we have a COES Medicaid provider, and they're very good. I'm from Orange County. We have a COES Medicaid provider, Medi-Cal provider, and they're the only provider of Medicaid Medi-Cal services, and they're very wonderful. And the care is really good, and there seems like a really good intent to do things. But they've really been moving at glacial pace with respect to palliative care and anything surrounding it, advanced care planning, even use of the pulse. It's like, well, we'll get there, and the state doesn't have a plan for us yet, and we don't have to do anything yet. And they're not... I'm not complaining.
They're not Sheryl Sandberg is what you're saying.
Right.
I got it.
So how can we in the community who have a responsibility to be the voice of the constituents they serve, and I actually I chair their One Care Connect dual eligibles member advisory committee. So what could someone like me say to the leadership there, get going?
I'm
what can I say
Cal
from you?
Optum
How
is
can
still
I quote
dragging
you?
their feet with you in Orange County. So I think this has been a conversation with our chief medical officers. So we get all of the different plans, chief medical officers together about once a quarter. We get the CEOs together too, but the CMOs, this has been a topic where we have, and I see Bob hiding over there in the corner, speaking of calling out people. When Bob was at Partnership, they were one of the COES that was actually superstars in terms of they had a great program on their own. They were demonstrating best practices. They were kind of both cutting the path and leading the way. And so we like to bring Bob out actually a lot and say, hey, COES and other plans, because it's not obviously just the COES, to say this is how it can be done correctly. A lot of these benefits and services under the palliative care umbrella are something that we already pay the plans for. I will roughly translate what Cal Optum is saying when they say, well, we don't really have a plan from the state, or we're not quite sure what they want. That's code by the plans for saying we don't have a specific rate, or we don't see a change in our rate structure in order to either pay for these palliative care services, or we're waiting for the state to see if they're going to pay for palliative care on top of what we already pay for. I think that the question's still out on that, just because if if you bundled all the different types of palliative care services together and said, how much does the state currently include in the plan's capitation rate? I'm making a number up because I don't really know, but say it's 80 to 90% is already included in the rate, but that final 10% is something that we need to actually affirmatively put into the capitation. That may be what the plan is saying is we don't really want to do anything until we both get a forced, you have to do this, but it's also one of those things where they want to see the rate. But I think there's probably going to be some continued technical discussions with the plans in terms of here's who you should be doing palliative care services for, because we identified some kind of key disease states, end-stage cancer, COPD. Yes, thank you. Some people know my policy better than others, including me. And so I think the plans, there's this dance going on with us, which is if we're putting a delay in, they want to see the rate to make sure that what we're asking them to do is both covered by and inclusive of what's included in the rate. So it's a little bit of a chicken egg, but I'm more than happy to talk with you offline about maybe having a conversation with CalOptima. Yeah.
Thank you, Director Kent, for the vitality of your leadership. It's one of the things that helps California survive these dark times. Thank you. We have two different entities governing insurance coverage in our state government, DMHC and DOI.
We're the only state.
Yeah. and there's a spot bill on the floor regarding another proposal for single payer, something we haven't seen since the Schwarzenegger administration. During these times when we're looking to find any economy to save money to use and apply to people's benefit as opposed to administration, is there any prospect to unify the governance of benefits and enforcement in California?
Wow, why do you ask me these hard questions so early in the morning? I will say this. I get along with the Department of Managed Health Care because they oversee, let's see, if I have 22 plans, they have all but 5 of them. So 5 of the county organized health systems aren't regulated by a Department of Managed Health Care. There's one COS that has a Knox-Keene license. Everybody else is Knox-Keene. I think when people start to talk about big clashes of governance, both in terms of do you have 2 departments in California, CDI and DMHC, or when you start to talk about single payer, a lot of that is kind of driven by the friction and the conflict that's being had at both a federal and a state level. I myself don't necessarily have anything to do with CDI because none of the plans that I contract with are regulated by CDI, so it's not in my wheelhouse to give an opinion. I get along really well with the Department of Managed Health Care director because I had lunch with her yesterday, and it's like, oh, hey, what's going on with this plan? What's going on with this plan? I think that what's more important is, and this has been something that I've been really kind of dedicated to when I've been working in my department, is whatever structure it is taxpayers and consumers and purchasers and payers, they actually want to just see what they're paying for. And so we've done a lot of work to be both better stewards in terms of transparency of the money. I think when you talk and when people have proposals like this, is they feel that there's a lack of transparency, or they feel that there's something that they can't quite put their finger on in terms of who's regulating what, and are they using different regulatory structures to avoid oversight. And I don't necessarily know that that's the case in truth, but I think that sometimes people feel that way. I tend to look at it as plans need someone to oversee them, and in some cases it's not only Department of Managed Health Care, it's me, because I hold them to a lot of different contract terms that in some cases are tighter than Knox-Keene. But then if they also happen to do business in covered California, they also have another entity in which they have to be very responsive to. And so I don't worry about plans being over-regulated, but I also happen to think that it's kind of that mama bear, papa bear, baby bear, porridge too hot, too cold, and just right. I think in California we have it just right. There's other states that are much more kind of Wild West. And some of this stuff at the federal level in terms of what they're talking about in terms of market changes is you're going back to a place in which plans had a lot more bad behavior, and that causes me a little bit of concern just because I don't know about you, but how many of us have like pre-existing conditions, such as like being alive, and so I think it frightens me a little bit to hear people say, well, let's get rid of all these market issues because it's tamping down competition. And I'm like, you mean providing coverage to people who actually want to buy it, but you don't want them because they may or may not get sick? Anyway, long-winded answer is I think I'm going to let the legislature decide how they want to regulate insurance in California, and then no matter what decision they make, I will continue to do business with whichever regulatory agency is regulating my plans. You're welcome. Yes?
Jennifer, thank you for many years of leadership. My question follows up on one you were talking to earlier, which is assessing the budgetary impacts of 1004. I mean, do we know that it would actually be more expensive? And I'm curious as to how you're approaching that in terms of assessing the actual impacts that it would have.
Sure. So there's a couple different things when you're part of the administration family. There's just a straight up cost in terms of staff, right? So we have some staff requests that have been postponed. And these are people that would be primarily in our managed care quality monitoring division that would be doing oversight of the plans in terms of, here's your requirements for palliative care, here's the all plan letter, are we doing like surveys and medical reviews of the plans on an annual basis to make sure that they're actually following the guidance that we've done. And that's not just for 1004, but in general, that is how our plans are overseen by our staff today. So we need just more eyes to do that work. That's part of the fiscal cost, and it is very small in the grand scheme of a $100 billion budget. The other cost that finance looks at is when I talk about this kind of remaining little percentage that we're not quite sure is included in the plan's rates for palliative care services. A lot of that may be staff time or coordination of benefit types of discussions, which is not necessarily here's a piece of durable medical good, or here's a pain type of treatment. There's a lot of things that are direct costs, but there's probably a little bit of people time that we need to include in that capitated rate. That gins out to be, and when you certainly break it down into the plan's rates, a small but consequential piece of general fund. Part of the discussion, and I think this is why the governor signed it a couple of years ago, is we recognize that to the extent that you have individuals that are being cared for at home, avoiding unnecessary ER or inpatient utilization, that there's absolutely cost savings on that end. So that's certainly taken into account. But how we budget in the world of our program is we look at what the actual expenditure of dollars is going to be, and you certainly take into the savings, but it doesn't always net out, right? Because they're like, whatever happens is we will be spending more money this year than last year, and while we may have cost avoidance, you never see our budget go down, right? So that's how finance looks at it. Is we come and say, hey, we'd like to do this. We think it's going to lead to some cost avoidance, but savings in our world is really not a true sense of the word. So it's a little complicated, but that's how we both have to account for it, but I think there's an acknowledgement that there's absolutely just both a human benefit to the service, as well as it will show savings over the long haul, which is why it was signed. It's just one of those immediate current year situations in which finance just said, we need to put a stop to new initiatives.
Thank you. So it sounds like the uncertainty is really the biggest part of it.
Yeah, that's a very big thing for us, because again, I think what the governor is very mindful of is, to the extent that there's something that happens at the federal level that requires a massive conversation in California about what we do, about the Medicaid program, and coupled with a state budgetary issue, he is the last person that wants to both start a new program and then a year from now be like, nope, I got to cut it all. And so I think what you see is someone who is appropriately trying to gauge how much do I bite off now versus I need to kind of get a little bit farther down the road and decide if that's something that we should invest in, or if I'm going to have to pull everything back, then I don't want to start something and then have to scrap it, which I can respect, having been part of the 2008 discussion. So,
thank you.
Hi.
This sounds like a real balancing act, so maybe we should get a geriatric fall specialist involved here. So my question goes towards the role of metrics as we look at palliative care, because we all know in this room that we cannot keep, it would be the wrong thing to keep palliative care confined to a palliative care service. So we have to be looking for palliative care throughout our system. I'm wondering about the role of just displaying metrics. We've seen that as a powerful tool, but if we're to be able to start getting reports about palliative care aligned measures, whether it's advanced directives, whether it's the chemotherapy treated in the last 30 days of life, those types of comparative metrics would not necessarily directly support palliative care, but all paths from those metrics will lead to palliative care. And any comments about how we might do something like that?
So, and I'm going to cede to the experts in the crowd. Are there established HEDIS measures for palliative care in any way, shape, or form yet? Does anybody know? NQF measure, but not HEDIS yet. So I think that's a great question. So a little bit kind of more background about how we work in managed care is we like established measures and that have been kind of vetted and peer reviewed and are kind of empirically established, because what we can then do is we're going into plans and we're doing apples to apples comparison, right? Which is, under this measure, did you do X, Y, and Z? And so when we start pulling HEDIS measures and requiring all the plans to send us their data, our external quality review organization takes all of that, and we have aggregate quality scores for all of our plans on a variety of HEDIS measures that we've chosen and selected. To the extent that there is not a HEDIS measure, but there may be another established measure, we're certainly open to adding it. We add 2 or 3 measures a year. We don't add a whole lot more than that because we keep the ones we have, we add new ones, and it's too hard to then tell the plans to go in 25 different directions, because everyone's always coming in and saying, hey, we want you to measure this or measure that, and we're like, we need to pick and see what we want to do. And so like this year we added, for example, 30-day readmits, right, off of inpatient utilization. And so what we do then is we wait for that data to come in on a year basis. We look at it, and then we sit down with the plans and say, here's how you did, and here's how you did across all the different plans. We benchmark our managed care plans on a quarterly basis and post them publicly. So we have quarterly reports dating back for over 2 years. And we, in some cases, expose them, both the good and the bad. Kaiser is always at the top. And I would make a joke, but I'm just not going to. And then I have lots of other plans that are at the bottom, and they know who they are. And in some cases, that has led to some uncomfortable conversations with them, which is if you don't get yourself off the bottom, you may not have a program to participate in much longer. And then there's a bunch of plans that are in the middle, and it depends on who they are, and it depends on the measure. I think that you would see from us a real willingness if there was a true kind of vetted and accepted tool that's not like a one-off type of measurement for palliative care. We would certainly be willing to talk about putting that into the plan's measurement, because again, if you don't measure it, you don't know what's happening, and then once you know what's happening, then you can make a lot of different decisions after that. And it's amazing kind of what transparency does. Again, back to this transparency issue is, once we started showing what the plans were doing on quality measures, some of them got a little bit more interested in wanting to get themselves off the bottom, and then others are continuing to put in some performance reviews and or quality improvement projects on their own, not at our urging. And then the ultimate weapon is I can put them on a CAP, which is a corrective action plan. I can sanction them, which we just did to Kaiser, and we can ultimately decide that we just don't want to do business with them anymore. So we have kind of a whole scale of tools and how we get plans to do better by our population, and palliative care can certainly be one of those.
Certainly, and my only thoughts is that if we look at this as community palliative care and we're an early adopter, there may not be established this is the best practice, but by using that comparative data as an early adopter, then perhaps we could generate more
Yeah.
interest.
Or you pick the one kind of element that's the most easily or readily measured, and by that, it's kind of like the crack in the door, and then it kind of, I think, you guys all work in the community in terms of helping both providers and others kind of grow the service, and I think if you have one measurement, it also allows you to kind of push it open just a little bit more the longer it continues to go.
Thank you.
Are you pulling me off?
Yeah, I'm just jumping in here.
Okay.
We are at 9:15, but I wanted to just say to you that you have a room here full of people who are supportive of palliative care, and thank you for sharing the story about your father. Very profound. And I think a lot of us feel like regardless of what happens politically with healthcare, that the future of healthcare is better value for our dollar, person-centered care. And if you look at palliative care, I'm going to make the pitch that palliative care is in and of itself embodies what we want healthcare to become. So I just want to put it out there that's if we can help with kind of moving forward, thinking, regardless of what happens politically, that you have a whole community here.
I appreciate that. Yeah, thank you very much. All right. Enough of the nice stuff. Thank you very much for having me, and I would just like to say, I mean, I appreciate the words, but I think, you guys work in a very hard world, and we all work in hard worlds, but I think you guys, really have a dedicated, passionate cause, and, to the extent that we can do stuff together, I am all yours, so thanks for having me.
Thank you, Jennifer.